Hi, my name is Hady Lichaa. I'm an Interventional Cardiovascular Specialist at Ascension St. Thomas Heart in Murfreesboro and Nashville, Tennessee, United States. It's a big pleasure to present to you today in the EuroPCR Got Talent session, a new technique that will hopefully change your practice, titled Right Heart Catheterization right from the anatomical snuffbox. I have nothing to disclose. So Radial first has been an unbelievable technique in terms of morbidity and mortality for the patient, but some of the operators are nostalgic about the fact that they can have a right heart cath done with a sheath right next to the arterial sheath from a femoral approach. So this technique brings this back, and through some thinking a little bit outside the box, makes it a simple procedure which has a win-win-win for everybody, the patient, the operator, and the staff. So instead of having two access sites, especially from the upper extremity, from an antecubital and basilar vein access to get to the right heart, in addition to the radial traditional access site, some operators prefer to still stick the groin and go from a femoral vein, which has its downside from a patient and operator perspective and morbidity perspective. Some other operators prefer a different access site, which is the internal jugular vein. This new technique allows for two access sites, both arterial and venous, side by side from the distal anatomical snuffbox. We take advantage of the anatomical course of the cephalic vein, distal to right next to the distal radial artery in the anatomical snuffbox. And as you see here on the ultrasound, it is superficial to the radial artery and is quite accessible most of the time, and is large enough to accommodate a 5 or 6 French sheath. And this allows for the fact that the venous and the arterial sheath are side by side instead of two separate access sites from the upper extremity. So it's a win-win-win for the patient first, for the operator, and for the staff, and I'm going to explain that in detail in the next few slides. So in terms of radiation exposure, instead of the operator leaning forward and getting into the radiation beam, this allows for the operator to step away from radiation and not only make it comfortable for the operator, but also the patient in a normal, natural, ergonomic position. Instead of two access sites from the antecubital or basilar vein, you have two sheaths side by side that can be that can allow for hemostasis at the same time instead of two separate hemostasis, which accelerates the patient's throughput in the cath lab and makes it convenient and comfortable for the patient and operator. This is a video showing the access technique of the distal cephalic vein. As you see here by ultrasound, it's very visible, and it allows for the placement of a venous sheath next to the arterial sheath. And basically, we use a tourniquet to compress that distal cephalic vein in order to increase the size of it. You see it here without a tourniquet, and with the tourniquet, the size of the cephalic vein becomes as big as the radial artery most of the time. You ask yourself, why not radial veins? Radial veins are usually very small, even with a tourniquet. The angle of access is very shallow. An ultrasound probe, especially hockey stick, is recommended without too much push in order not to collapse the vein. Very gentle access with an angle at 30 degrees. The wire is advanced, and if you face any difficulty in placing the wire, rotation of the needle bevel will allow the wire to go in the right direction. Then after that, the radial artery access site is performed at a little more 45-degree angle. The sheath here, a 5-6 French sheath was placed in the cephalic vein, and another 5-6 French sheath will be placed in the radial artery. The two sheaths are outlined side by side. They're covered by an adhesive dressing and a balloon-tipped 5 French right heart cath, which can be also a 6 French in some cases of larger cephalic vein, is advanced through the superficial venous system of the upper extremity, which has multiple variations as shown on the slide. A venogram is usually not necessary unless difficulties are faced and in order to advance the catheter, and most of the time we are able to reach the wedge position in patients who are 162 centimeter and shorter. In terms of hemostasis, the radial artery sheath is removed first. Then patent hemostasis is applied with a compression device. The venous access site is removed second, and the major advantage here is there's no need for additional time of venous hemostasis since this area is compressed by the same compression device, which makes it convenient for the patient, operator, and staff, and much more rapid throughput in the cath lab instead of dual hemostasis as shown in this slide. The operator can choose for a sheath or a sheetless technique depending on the height of the patient. The sheetless technique allows for an additional 7 to 10 centimeter of catheter to advance to the wedge position, since the catheters are 110 centimeters currently before industry starts hopefully making longer catheters. So in terms of why is this important, the safety of superficial venous access is obviously obvious. The comfort and satisfaction for the patient, only one compression device for both arterial and venous access sites. It's faster patient throughput through the cath lab, better ergonomics for the patient and operator, less radiation exposure since the operator is stepping away from the antecubital area. So the essentials to remember is why is this important? It's arm venous access. Ergonomics are usually pretty complicated and allow for more radiation exposure in the traditional sense if it's done from the antecubital or basilar vein access. We suggest the distal cephalic vein access, which is very accessible and convenient. It is done under ultrasound guidance with or without a sheath, depending on the height of the patient. And it's important due to its safety, comfort, convenience, better ergonomics, less radiation exposure, and better and faster patient throughput through the cath lab. So it's a win-win-win situation for patient, operator, and staff, and does not require any fancy equipment. It can be done in any cath lab. It is fast and convenient, and hopefully this will change your practice. Thank you very much.